The statements and opinions expressed in this episode are those of Dr. Sigman and his guests, and do not necessarily reflect the views of Veradigm.
It's time to do healthcare smarter. This is Smart Medicine, hosted by Dr. Scott Sigman and powered by Veradigm. The doctor-patient relationship is something truly special. As a physician, you have the power to leave a lasting mark on someone's life. That impact can be profound and deeply meaningful. But the flip side is just as real. A bad experience with a doctor can affect someone as well, leading to frustration, sadness, and anger. And now with more screens, more software, and more technology walking into the exam room, that relationship is going through a serious shift. So what happens to trust, empathy, and human connection in the digital age? To help explore that, I sat down with Dr. Danielle Ofri. She's a renowned author, a primary care physician at Bellevue Hospital, and one of the top voices we have on the emotional core of clinical care. Today, we're digging into the evolution of the doctor-patient relationship and what it takes to keep patients at the center, even as the world around us changes. Dr. Danielle Ofri, a prolific author, frequent contributor to the New York Times. Her work explores the doctor-patient relationship, communication in medicine, and the emotional core of clinical practice. Welcome to the Smart Medicine Podcast, Dr. Danielle Ofri.
Thank you. It's great to be here.
Fantastic. So, Dr. Ofri, we know that you're still a practicing primary care doctor at Bellevue Hospital. So I am somewhat familiar with the history, and I would think that working at Bellevue really has provided you an incredibly unique perspective on healthcare. Talk about the front lines of providing care to some of the most underserved populations, for example. So I'm curious, how did that influence you on your perception of the power of empathy in healthcare and how you learn to communicate with your patients?
Well, one of the things I'll say about a place like Bellevue, it's not just, and we think of it often as an underserved population, but I think of it as one of the richest, most varied populations you'll ever meet. And one of the reasons I love to work here and haven't left and probably won't leave until I'm out on the gurney is because I'm always meeting new people from new places, learning new things. And I know it sounds a little bit hokey, but there's never really a dull day. I just had patients this morning, and my patients really come from all over the world and bring so much to the table. So both as a physician and as a person, it's such an exciting and enriching place to be. And of course, we're also an academic medical center, so there's plenty of teaching and things to keep us on our academic toes. But I think what it offers you is the recognition that you can't make an assumption about anyone. When someone walks in the door, you don't know where they're from, what language they speak, how they got to where we are at this moment. And I think we often forget to ask that question. Now, sometimes it's a literal one. How did you come to the United States? Because many of my patients are born elsewhere, but even how you came to be here at this moment. And people have incredibly moving, varied stories of how they got to where they are in their life. And that gives you the chance, I think, to give you the first part of empathy is to imagine what might it have been like.
I'm genuinely looking forward to our conversation. I practice in Lowell, Massachusetts, which is a very diverse population. We have people that have come from all over the world for successful immigration to join their families who came before them. And so I think this will be a really interesting conversation. Can you provide us an example again of a patient interaction in your earliest days about coming to Bellevue, which sort of opened up your mind to the need and understanding of communication with patients?
Communication takes so many forms. And I think about when I was a medical student at Bellevue, my first day on the medical wards, we are doing rounds and we get a page. There's an admission right now down in the EW. Got to come right now, cancel rounds, run down. And it's an elderly gentleman clearly in distress and a lot of people, and someone throws on an echo probe and there's a huge pericardial effusion. I mean, big amount of fluid around the heart. And someone takes out the biggest needle I've ever seen in my life, stabs it in his chest. And I'm watching this on my very first day as a medical student. I thought, what can I as a medical student do? And here I am, of course, relegated to the foot of the bed because that's where you are. The only thing I could see was his feet. And I thought, I wonder if like a small foot massage or foot rub would be helpful to this guy who's really stressed. And so I got on my couch and just started to rub his feet. And later on, when we spoke, he remembered that. And that was like the entree. And I mean, I had no role medically at all. I didn't even know what a pericardial effusion was, but I did know that he was suffering and that there are always opportunities, even when we have very limited skills. So that's a very early memory from Bellevue.
Oh, I love that. I was involved in some of the craziest clinical care in COVID in the worst of times in March and April. And I just vividly remember he could barely breathe. We treated him with our laser. He sat up. It was the very first patient that we had treated. And he literally looked up at me and said, "Doctor, I'd like to order a chocolate shake." And it was just it's such an important moment for me, such a small detail, but something that is so ingrained into my thought process. So we're gonna take you through a little process here. I thought it would be interesting if we could sort of go through the past, the present, and the future of sort of physician communication. So let's start with the past. I thought that would be a sort of a good place to go. In the history of your personal evolution of the physician-patient relationship, what it was like in Bellevue when you first started. Did anybody give you any special training on communication with your patients? Was it a trial by fire?
Sure. There was actually very little direct didactic parts about communication. You just showed up on the wards. That was it. And of course, we didn't really have attendings around mostly. And so we really were on our own. It was just our residents who were scant a year or two older. But what I did notice, the attendings did come for 2 hours a day to round on the new patients with us. And I remember one in particular, this GI attending, hepatologist from Egypt, very formal gentleman, bow tie, buttoned up white coat, always smartly dressed, pressed pants. And I remember thinking, how will this physician who's so formal and kind of British trained have any connection to our patients who might not speak English, might be substance users, might be homeless. And yet whenever we brought him to see a patient, the patients loved him. Very clinically curious about patients. He asked them lots of questions. He demonstrated that he wanted to know about them and how to help them. He asked extended questions, listened carefully, did a very thorough physical exam. And even when the physical exam wasn't necessarily so helpful, the exam itself was a sign of respect that I care about you and I'm going to help figure this out. And I always remembered how this very sort of old-fashioned doctor connected in a way that I might not have expected, might have thought that it really would be a distance. So in looking for role models, I remember thinking someone who seems interested in the patient and who they are as a person, as a patient, how to get them better is a way of communicating.
Wonderful example. And so it just goes to show it doesn't matter what you wear or what you look like. It's really about your communication skills and being able to really direct and develop a relationship with that patient. I think that's wonderful. So continuing on that theme, can you provide sort of a foundation or the framework for how you developed your empathetic sort of philosophy of communication with the patients and really how that underserved and diverse population of patients at Bellevue really helped you to develop that foundation?
When I look at the students that we train now and the residents, there's not really any bad apples in the whole lot. I think that everyone comes in empathetic. They come in interested, respectful, able to communicate, and we tend to stamp it all out of them. So I feel like our goal is not to create anything new, but to help preserve what they come in naturally. Most medical students identify, in fact, more with the patient than with the staff because they are on the same level, more or less, with the patient. And so helping to show that. And I think that I don't even think so much about getting an empathetic skill or philosophy. It's trying to be true to who I am. I do try and be an authentic human being as much as possible in an environment that doesn't necessarily laud that or provide for that. And in teaching, I think our goal is to demonstrate that despite the chaos, despite the commercial pressures, we can put a line in the sand of that we as physicians or nurses are also we as the people. And that we come to this with our medical skills and our humanity as regular, ordinary human beings who care, who listen, who want to know. And again, the clinical curiosity of my mentors really stays with me. Being interested and focused on a person and listen to their answers is 80% of the way to go to connect with someone.
All right. So piggybacking on that in particular, I think it's interesting. So do you believe that the traditional image of the trusted family doctor at this point has offered something that we're now missing sort of in our modern, digitalized and specialized medical world, right? We're all running around. We've got EMRs. We got a cell phone in our hand. We got to do the discharge summary, all of these things that we're doing. But, I think that the trust in physician is super important. So how is that still played out compared to what you were seeing early in practice?
I mean, trust is everything. I'll just start there. Whether you're an intensivist, a primary care doctor, a proceduralist, if the patient doesn't trust you, you will not get very far. They won't take your medicines. They won't do your procedures. They won't take the vaccination. So I feel like that is one of the most important currencies that we have. Of course, we need to be skilled, stay up on our medicine, be up to date. But really, the trust is so important. And of course, yes, we've lost some of that, partly because time is ever more precious and there's a lot of chaos going on. So things that I try to do to, say, push back, but hold off a little bit. So I know we all need to write and document while we talk to patients, but you can take the first 2 minutes and look right at the patient without writing, ask them how they're doing, what's up, and listen, and ask a question follow-up that reflects that you have listened. And that 2 minutes is money in the bank. And when I counsel my residents and PAs, that although it seems inefficient, it's actually remarkably efficient. If you take that time, and then I might say, I don't want to miss what you're saying. Do you mind if I take notes while you speak? And then I'll sort of indicate why I'm going to be writing. So I'm turning away a bit, but I've acknowledged that. And that it's in service of you and not just because I want to get my work done quickly. So trying that type of thing, but letting the patients speak until they're done speaking. And I once decided to see how long would they talk if I didn't cut them off. Most patients would stop in 30 seconds, 60 seconds, 90 seconds. Most don't talk on forever. And you can let them get out what's on their mind and don't cut them off. You will be actually quite efficient and you will have gained a little more trust.
I love it. So let's stay with that for a minute. So I know personally, I have 3 separate medical record systems that I have to deal with on a day-to-day basis. I've got one for my clinical practice, another one for my surgery center, and then another one at the main hospital. And so every day as physicians, we're typically asked to do more, hit more clicks, spend more time with screen time than we are with actual face one-to-one time, and spending way too much time in front of a computer. So you've written about how the bureaucracy, electronic medical records, and time pressures are straining to the human connection. You did give us some examples, but so give us how the realities of how you feel that those things impact the doctor-patient relationship today.
Well, it becomes that there's really, instead of a sort of a 2-person tango, it's a 3-person menage a trois in the room. It's you, the patient, and then the computer. And you can see that so often the main interaction is the doctor and the computer, and the patient sort of sitting off to the side, gazing at your file cabinets. And I try to minimize that because I think it's so alienating. Or I'll try to sort of show them what I'm doing or read what I'm doing so they understand I'm not just randomly ignoring them, but I am typing out your mometasone prescription, or let's order that orthopedic consult, or whatever it is that we're doing. So I try to pull that in, but it really does impede our ability to talk and trust, particularly, I will say, with chronic illness. Because most chronic illnesses that we deal with today, diabetes, high blood pressure, heart disease, depression, they're not easily cured. In fact, most of them are not curable at all. And this is going to be a long-term process with education, lifestyle changes, medication adherence, a lot on the table to make this work. And that just is going to require ongoing communication and trust. And the, focus on the EMR really detracts from that. So if I want to get anywhere with someone's heart failure that's resistant to medications, I need to spend more time on the talking and some eye contact than on making sure I have the latest medications on there, because if they don't take them, they're not any good.
Yeah, I'm a huge fan of what you're saying. And obviously, an orthopedic surgeon that specializes in knees and shoulders has a little bit different experience than dealing with chronic disease. And so our appointments may be obviously a little shorter than you spend time with your patients on these very important issues. But I'm sort of going to harken back. I, at this point, I was one of the first doctors in our practice to hire an actual scribe, someone that walks around with me and holds the computer. And I have a few golden rules, which are actually very similar to what you described already. First is I always sit in a chair lower than the patient so that they feel empowered. I never interrupt when they first start talking. I loved what you were saying. You're absolutely right. Usually within 2 minutes, the average person can articulate why they're there, We call that the history of present illness. And we can, with that information, our brains are already ticking as to what we think are going on. I always make some physical contact, even if it's a post-op patient or whatnot, but I may tap them on the shoulder. Just want to let them know that I'm also physically communicating. And I never, ever have my hand on the door while I'm talking to a patient. I think that's a major faux pas. But I think the message that I'm trying to present here is that since I've hired this scribe, my personal experience as a physician is so much better. I have dramatically reduced my anxiety because I'm spending time focused on the patient. I may look at an MRI, but I don't have my face deep into a computer. And so with that, I thought it would be great. You've already given us some, but please provide us a few more real life tips on how you can improve that empathetic communication with your patients in this crazy digital age in which we work.
We touched on a physical exam, and in truth, and maybe less so in orthopedics, but in internal medicine, the physical exam is actually not that helpful. There's almost nothing that will come up in physical exam that I haven't predicted from the history. Occasionally you get a surprise, which is why we examine everyone, but most often you're just confirming something. However, in today's day and age, I find that the physical exam has taken on a new power, and that is the chance to communicate directly without the interference of technology. And I find it's often only during the physical exam does the patient then reveal what's really on their mind, whether it's the cough they forgot about until I listen to their lungs, or the domestic violence or sexual abuse that's happening only when they're relaxed on the table and I'm gently palpating their abdomen. And I think there's the sense of contact, physical contact, touch in a sort of safe environment is often a way that patients can feel more able to trust you than sitting across a desk with a computer. So I use the physical exam even when I don't even need it. I use it all the time as a chance to reconnect without technology. And that's been a real boon to preserve those few minutes of touch and contact without technology.
Great advice. I really love that. So I always say to my staff that our patients' time is as valuable as ours. And so often we see our patients who are waiting an hour in the waiting room to be seen by a doctor. Maybe they get 10 minutes with them. So, that's a major focus. And I feel that the efficiency of managing all of that in this setting of this electronic world and the extra things that we have to do can be difficult. So can you describe for us, because you've talked about the tension between efficiency and empathy in today's clinical environment. How do you make a balance between getting everything done and still being empathetic and communicating with your patients?
Well, working like a dog, that's part of it. Really, and there's a little frustration level of how many hours outside of work time it takes. Back in the day, I could walk into a patient care session unprepared and just prep as I'm seeing the patient. Now that's impossible. So I try to take the time, and where I squeeze that from is a whole other story, but to prepare so I'm not walking in cold, that really helps. I also try to remember whenever I see a patient to make a note of what's important to them somewhere, because often it's not what their major illness is. I have a patient whose adult daughter in her home country has cancer and she can't go back to visit because of visa issues. And that is the most important thing for her. She couldn't give two hoots about her diabetes or hypertension that I'm interested in. So I always know to ask about that first, and then we can get to her medical issues. And so keeping track of those things, wherever in the social history field or in my own private note, remembering something about that patient that's important or key, or particularly if someone is here in this country working as a cab driver, but was an economist back in their country, I want to remember that. So that's one thing. The second thing is I try to acknowledge, and I apologize and say, I know that we're really rushed for time. I want to make sure we get to everything you have on your mind. Why don't we today pick 3 things of your 20 concerns, right? If we do all 20, they'll all get short shrift. How about you pick 2, I pick 1, and we get to those. And so prioritizing a bit. So I haven't ignored the other ones, but being realistic that I can't do all of them in our short session.
What I love about this conversation so far is that the solutions we're talking about aren't complicated. As Dr. Ofri said, it might be something as simple as remembering one small detail about a patient that makes them feel seen. Her connection between empathy and efficiency really struck me as well. What if giving patients just a bit more space to talk ends up saving you time in the long run? Patients will tell you what's going on. You just have to have the patience to give them the mic. Before we dive into what this means in the age of AI and digital health, this episode of Smart Medicine is powered by Veradigm. If you're a provider looking for technology that frees up your time and helps you get back to what really matters, connect with the team at Veradigm. All right, we've got telehealth, digital scribes, EHRs, and AI all knocking on the door. So next, I asked Dr. Ofri what it means to keep the patient front and center as technology continues to shape care. So the COVID epidemic in particular dramatically affected all of our lives and has still influenced how we interact with our patients. For the longest time, telemedicine was taboo in medicine. It actually, you were never compensated for it. And so therefore it wasn't something that most of us engaged in. But with the onset of COVID, that's all those rules were relaxed. So there was a lot more interaction, both audio and video calls, which most of us were involved in. But I have to say now, personally, I have seen a real fall off on the need and the desire for the telemedicine visit. But what has been your experience with telehealth and how you think it has really affected our ability to communicate with our patients and our relationship with our patients?
I was a skeptic too. When we were in the middle of COVID, I just sat there calling patients. I thought, oh my God, this is so depressing. Is this what I'm going to do the rest of my life? But I have to say, I have a newfound respect. So for example, yesterday I had patients in person, and a couple didn't show. Now, in the past, that was it. They didn't show, so they have to come back my next available in 27 years. But now I could call them. Oh, they forgot, convert to a televisit. I get to adjust their insulin, talk to them about what's going on, make sure they get their vaccination. So we have done medical care. We've advanced their medical treatment. So I find it's a real great adjunct. And then a lot of my patients, they have difficult lives. They're working 3 jobs. They live far away. It's 3 buses to get here. And sometimes it's really hard to come. And if I can rescue that visit, maybe it's not quite as good, but boy, oh boy, if we can get that as opposed to missing it, that's a huge win. The second is that it gives patients flexibility and it gives the physicians flexibility. We have a little bit of agency. So I still preserve 1 session of telehealth visits, and that enables my patients, they don't have to come in. If I have to be at something or take care of my elderly mother and get down to her, I can do the session there. So it's given me a little bit of flexibility. And for patients who are on telehealth, you can move things around a bit. You're not waiting there. And you say, hey, do you mind if I call you an hour later? And they're okay. It's fine. They're not waiting. So it has injected a bit of flexibility that we never had before. So I think it's been a great adjunct. I don't want someone to just be doing telehealth. Sometimes there's some patients who don't never want to come in. Like, you have to come in once a year. You've got to come in. But I actually think it's been a great help. And the last thing I'll add is it enables me to essentially do a house call. And so often I get to see where the patients live, the situation. I get to see their pill bottles, how they're storing their medications. There's lots of things that I wouldn't have gotten. I get to meet the caregivers, the helpers in the family that I would not have met otherwise. So that's actually been a real boon and extra enhancement to our medical care.
Yeah, I love that. The technical digital home visit. I think that's really quite profound, and I've actually never heard it that way as well. And I agree, especially for patients that may be coming from a distance. I found it to be a great adjunct, not something I'm comfortable doing routinely, but for the right patient and for the right issue, I do think it really has made us better as one more tool. So I was very pleased to hear, it was at the start of our conversation, when you had mentioned that the young doctors in training really seem to want to be there. And they seem to, like, that was the part that they got, right? They don't really know how to be doctors yet, but it sounded like they like people. So being able to learn how to communicate is so important, yet that's not something that we're taught in medical school. So can you provide some sort of real life tips and pearls for how we can be better as far as our communication, emotional support for our patients?
So I always start with telling my trainees, students, and residents to pay attention to the people around you, your residents, interns, fellows, attendings, nurses, and observe how they interact with patients and see who's successful. It's not necessarily the, quote, smartest person in the room, but you'll see some people will endlessly knock heads with patients and call them non-compliant and difficult patients. And some people seem to go smoothly with even the most upset or angry patients. And those are the people who you want to model and see, what is it that they're doing? Or even ask them. So I often, like, if we have a patient angry in the waiting room, instead of calling security, I say, you know what? I want to go out. Let me bring out the students with me because I want to model for them, how do you deal with a patient who's really frustrated or angry? And I always come in and say, hey, what's going on? It sounds like you're really upset. Can you tell me what's going on? Just tell me the story. Give them the stage. And people want to tell their story of what's going on. They've been waiting hours or days or weeks to tell their story. So I demonstrate that. I always refer to patients very respectfully, Mr. or Miss, ma'am, sir. I never yell the name in the waiting room. I feel like our patients get treated poorly in so many situations. And I think we have a chance to be respectful. So helping that and say, boy, how can we help solve this? And I think a lot of my patients who have difficult to solve symptoms, those patients are often very frustrated. They've got pain we can't explain, things that don't fit in easily, and they're constantly doctor shopping because they don't get anywhere. So often say, hey, you know what? Sometimes medicine doesn't have a name for all the things that are going on. It's still happening, this pain or this stomach symptom. Even if we can't name it, doesn't mean we can't try to treat it and solve it. So we're going to be this like research team, you and me, and we're going to gather data, right? And we're going to try some experiments, some N of 1 experiments. You keep a symptom diary of this pain. We're going to look at it. Can we find a pattern? Can we try some things, even without a formal diagnosis? So I always try to tell my patients that no matter what you have, we can always do something to work with you. We can't say, oh, there's no answer here, we can't help you, because that just makes patients really angry.
I think that's great because you described a few things. First and foremost was your ability to try and mentor and teach the next generation of doctors how they can learn how to communicate. But I think it's also important for our listeners as well that you also emphasized for patients as far as what they're experiencing and how they're trying to communicate. And that's what communication is. It's a conversation back and forth between the two. Really well said. So let's move now to the future. So we know that technology is rapidly moving into healthcare. You can't turn on a computer these days without probably going to ChatGPT to help us do all the things that we do. In the operating room, for example, we have virtual reality. I've now got augmented reality where I can look at MRIs and X-rays while I'm operating on a patient. And of course, AI is permeating all aspects of healthcare. So what is your vision of how we can protect the doctor-patient relationship in the future, given all of this technology that's coming down the pipeline?
So I'm not really sure if I have the answer to that. I'm definitely sure that we want to make sure that we're in control of this. But you can always close the computer. That's a simple way to keep it out. So we still have that control. We don't have to seed everything. And my, two concerns are, one is that we don't use technology, or the system doesn't use technology in order to then just make us work harder. Okay, now that you've got this, now you can see twice as many patients, right? Because that's not going to serve our patients well, or the doctors and nurses. And the second is that we don't have the technology sort of take over what it is that we do. I mean, think about if you're sick, and I mean really sick, you want someone to take care of you. And that is really not yet what AI can do. AI may spit out a great algorithm, and that's great, and maybe gets the right answer. But there's a difference between being cured and being healed. And I think we can often cure our patients with, I'll put that in quotes, obviously, but with some treatments, but they still will walk out of our offices not feeling fully healed. They have a bad experience. They feel like they were not well taken care of. They walk out with a bad taste in their mouth, despite their infection cleared or their fracture set. And I think that's the part that technology can't quite get to, at least yet. And that is our role.
Dr. Ofri brings up such an important distinction here, the one between curing and healing. So let's double click on that. The American Medical Association's 2022 study showed that 93% of physicians now see digital tools as a plus for patient care. That's up big from just a few years ago. But here's the catch. Docs are now juggling close to 4 digital tools on average, and many feel it's making things a little more robotic. As Dr. Ofri pointed out, none of these tools can look a patient in the eye and say, "I hear you." The future of healthcare isn't just digital, it's human. And the smartest tech will be the kind that gives us more time for the real work, building trust, listening fully, and treating the whole person.
But there's a difference between being cured and being healed. And I think we can often cure our patients with, I'll put that in quotes, obviously, but with some treatments, but they still will walk out of our offices not feeling fully healed. They have a bad experience. They feel like they were not well taken care of. They walk out with a bad taste in their mouth, despite their infection cleared or their fracture set. And I think that's the part that technology can't quite get to, at least yet. And that is our role. And I think we have to insist that we still have to make the human interaction. This is not a bank transaction. And so, calling patients customers or clients just seems wrong. They're patients, right? And we're doctors. We're doing a very particular thing. And I'd like to respect that. And that's still really essential. I'm happy to have AI to help me. I mean, God knows the last 2 prior authorizations, I'm happy to farm that out of ChatGPT. But when my patient is sitting there really frightened with a new diagnosis, I think that requires a person, because it's not just what to do. Maybe ChatGPT can tell us what chemotherapy to do, but it doesn't tell you whether to do that, or how we should do it, or why we should do it, or if we should hold off. Those are questions that really require a human connection. And that's, I think, where we excel. And we want to retain control of those critical aspects of medicine.
Yeah, patients first in everything we do. It is a human interaction. But my practice is about to embark on a beta test for virtual assistants. Now, I think this is really might be a fascinating way where we may see improvement with the use of technology. Literally, I'm going to be testing it relatively soon. I'm going to bring my phone into the room. I'm going to lay it down on the table next to my computer. And I'm going to just start talking to the patient. I'm going to get the history of present illness. We'll get their past history, the things that are bothering them. I can do a physical examination, talking out loud about what I'm seeing, and then come up with a care plan. And the phone will literally listen and do all of that, and then literally interject it into the electronic medical record in the computer without pressing a button. To me, that's pretty fascinating. That, to me, potentially helps to improve potential for physician burnout and anxiety for the doctor, and still communicating eye to eye with the patient. What are your thoughts on these types of tools? Will they strengthen or erode the doctor-patient relationship?
Well, I worry that it has a little bit of the ability to sort of, the way copy and paste used to, how we would just, in the hospital, every note is the same. I think it could be the same, because you need to edit these things. Now, my side gig is I am an editor. I edit Bellevue Literary Review. And so I spend a lot of time editing people's writing, and including my own. And boy, the first draft on the page, I would never want to put that out in the world. And I worry that people will just, it's kind of like the dictation. You just put it up and you don't have time to go back and read them. And if we don't do that, we may not be happy with what comes out. So it's going to require quite a bit of time to edit those things. There's also lots of things we say that I wouldn't put in the chart, whether for legal reasons or even for medical reasons. Let's just say if a patient has what we say a polypositive review of systems, everything is down. Now, if I listed every one of those 50 complaints, each one of those would spawn a huge workup. And I recognize that's not really feasible. And many of these things are smaller things and probably don't need to be a huge problem in the chart that requires MRIs. So I may be judicious in what I put down. What are the key things? I don't know if AI can prioritize like that. And then is there a legal liability if AI hears something and then I take that out? Am I now liable? I'm not sure who's liable for that. So I would say the jury's out. I think it has potential. What I would love it to do, forget that part. If it could scour the chart and come up with a chart review for me of what's happened to their 10 other specialty visits in the interim since I saw them, what were the imaging results, what were the lab results, and put that together in a readable form, and pull up for me the evidence for whether I need to get a CT in 12 months for this lung nodule or 24 months, that would be a great use of time. And then I'm happy to do my interaction with the patient the way I like to do it. But I'd rather it do all of that. What health maintenance we're missing? Can I go ahead and order the pneumonia vaccine because they qualify for that?
I think that's great advice. I mean, I look at my partners and I try to read their medical notes the way they are right now. And it's like, I don't know how they send it to primary care doctors, because half of them, I can't even understand what they did. So I think there's probably going to be a middle ground, right? I think efficiency and time is really important when it comes to the anxiety of physicians and physician burnouts, right? I really liked your commentary on the collation of data. As I said, I have 3 EMRs at this point right now. I am an orthopedic surgeon treating your patient, Dr. Ofri, but they are probably also seeing a cardiologist. They may have also seen a urologist. And so you're trying to manage all of that information and make sure that we're not missing really important documentation. So I think that would make that sort of collation process, which could be done before you even enter the room, I think would be really fascinating.
Yeah, I'm not sure that AI understands the reason for a medical note. I mean, to me, a medical note is sacred. I want the medical note to have that perfect inflection point of thoroughness and brevity, that if someone reads my note, they don't have to read anything else in the chart. They know what's happened to the patient in the past, what's happened in the recent, and I want my note to be better than that. So I'm not necessarily convinced it's going to be a great thing, but it could do other things. The jury's still out.
So we're coming to a close. We're not quite there yet, but let's try to sum up here a few recommendations for the patient, because it is a two-way conversation. So what advice do you have to our patient listeners out there when they're coming in to meet with their doctor as far as what their expectations should be?
So for many patients, they may have waited weeks, months for this appointment. They've built up this list of 57 things that they want to get to because they've been waiting so long. And so they open up that big sheet of paper with all those questions. And of course, that's when the doctor's heart sinks. And I understand why patients want to get all these things in, but to recognize that if you do 24 things, you'll guarantee superficiality for each one of them. It's not realistic. And so to really prioritize, and really, you could say to the doctor, here's the 3 things I want to make sure we get to. And if they don't get to it, stop them midway and say, hey, we didn't get to X or Y. Recognize that your doctor may have one thing they want to get to also. So really prioritize those questions. Many patients will come in with a stack of medical records from the other hospital and plop it on my desk, say, it's all in here, and hand me a 16-inch stack. And that's just not a possible thing. No one's giving us time to do this. So if there are important records, you can pick out the 2 or 3 things. Here's my cardiac cath. Here's the MRI report. That's really important, and prioritize that. But you should expect your doctor to pay attention and listen to you. And if they're not, find another one. There's most places in the US, there's plenty of them.
So great advice. So to my mother, Judy, who's always listening to our podcast, make sure, Mom, you prioritize your questions when you go into the doctor. Make sure you allow the doctor to also prioritize what they think is important, and expect your doctor to pay attention and make sure you're listening as well. Great advice.
And Judy, bring all your meds with you. Just put them all in a bag. Bring
all the meds, Judy. I love it. Dr. Ofri, we want to thank you for sharing your provocative viewpoints on the human aspects of health and well-being of the patient-physician relationship. You have provided our listeners valuable insights into empathetic, empowering communication. Thank you very much.
Thank you. It's been a pleasure.
What a powerful conversation. Dr. Ofri reminded us that in a world full of digital tools, the most important instruments we have as doctors might still be the simplest ones. Eye contact, a moment of silence, a hand on the shoulder. Those are the moments that define great care. Those are the moments that, to me, are smart medicine. A big thank you to Dr. Ofri for joining us. If you enjoyed this episode, make sure to follow Smart Medicine wherever you get your podcasts and share it with a doc you know. I'm Dr. Scott Sigman. Thanks for listening, and we'll see you next time.